my son when it's time to start.
Okay.
Because it's going live, I want to make sure you have the right time.
How are you, sir?
Good to see you.
Nice to see you as well.
Crowd so far. People still coming in.
This is one of our Narcan kits.
Oh,
We
fantastic.
keep in our patrol vehicles.
So I'm going to mention that, but I want you to cover that.
Great. I think I'm ready. Are you?
Yeah, I've been in my, no, actually been in the leadership. I want to thank everybody for coming to this Arapahoe County Town Hall. The subject tonight is going to be opioid abuse and the issue of drug dependency within the county. First of all, I'd like to thank our county staff, our AV department, who have helped set up this operation, and our communication director, Andrea, for all her help in getting the word out, and it looks like we've had a great turnout as a result of that. Thank you for taking the time to come here tonight to learn about the growing epidemic of prescription drug abuse in this nation. Tonight we've assembled elected officials, law enforcement, mental health professionals to help us better understand the depth of this deadly epidemic. How pervasive it is and how this community can effectively meet this challenging problem. Over the last decades, death from opioid overdoses have skyrocketed, exceeding automobile deaths in this nation. Since 2000, nationally there has been an increase of opioid deaths by 293%. Over 40,000 have died as a result of misusing prescription pain-killing drugs. In Colorado, those figures have risen to almost 301%, increasing the deaths from prescription pain-killing drugs since 2000. In addition to prescription drugs death, Colorado is experiencing an increase in heroin-related deaths by over 432% since 2000. Some experts believe that the increase in heroin usage is directly related to individuals moving from the more costly prescription drugs to a less expensive illegal heroin. Arapahoe County Board of County Commissioners recognized nearly 5 years ago that the increasing problem of opioid addiction was becoming a major problem among its citizens. I asked the Arapahoe County Sheriff and the Coroner to help form a task force to begin to address this growing epidemic. That small task force has grown significantly with the help of Dr. John Douglas, Director of Tri-County Health Department, Steve Odoricio from Adams County Commissioner, and the Aurora Mental Health Organization. Over the past 5 years, together we have initiated programs that have placed drug drop boxes in sheriff's offices, the local police departments, so citizens can turn unused prescription over. We've improved the state prescription drug monitoring program by making it more user-friendly for physicians and pharmacists, improved the state prescription drug monitoring program, and expanded the drug education programs for our youth through the Tri-County Health Department. The problem of pain-killing prescription drugs and the increasing use of heroin is not by any means over. We as a community must continue to work together for results to end this deadly epidemic. Tonight, our panel will help us better understand how far-reaching this epidemic is going and offer their opinions on how to solve this problem and save lives in the process. Thank you all for being here. I will start by asking Louis Pereira from the Arapahoe County Undersheriff to talk about the law enforcement aspects and what they're doing as a department to help begin to help address this issue. Thank you.
You can do that, or you can go up there. You can stay here. Sure, I'll sit here. Good evening. Again, my name is Louis Perry. I'm the Arapahoe County Sheriff's Office Undersheriff. Sheriff David Walter apologized for not being here tonight. He had another commitment. One thing that I want to talk about tonight is a program that the Sheriff's Office worked with the Office of Behavioral Health back in February of 2016, and that is to get Narcan into the Sheriff's Office, specifically in all aspects of the Sheriff's Office. So back in February of 2016, we reached out to Office of Behavioral Health, asked them if we could receive a grant to get Narcan into the detention facility. And the goal was when inmates come into our facility, we have about 17,000 inmates that come into our facility a year, and they meet with our classifications, our medical staff, and if they're deemed to be high-risk opiate users, they're then asked would they like to receive some training on how to properly use intranasal Narcan. And if the answer is yes, then what we do is we provide them that training. And once they receive that training, then what we do is we put one of these optimizers in their personal property. Upon their release from the detention facility, they go home with one of these. And I have several stories that I'll talk about sometime tonight that shows how effective this can be. And then back in, that was in February of 2016 in the detention facility.
What Narcan does, just so
sure. If someone is let's say they have overdosed on heroin, and in fact, I'll talk about a story here. I think it's a good segue. This is a 17-year-old individual, and deputies responded to a possible overdose victim, and CPR was being initiated by a reporting party. Upon arrival, deputies identified the victim as a 17-year-old male that was unresponsive. Based on the victim's presentation, the deputy prepared their Narcan kit and administered the dose. The victim was transported to the hospital. Later, while still in the hospital recovering, the 17-year-old victim admitted to the deputy that it was liquid methadone that he consumed, resulting in an overdose. and immediate effects. So a great response by our deputies. And like I had mentioned, the Narcan kits were first deployed in our detention facility. We expanded that in September of 2016 to our patrol services unit. We wanted to make sure that Narcan was available to all of our patrol deputies. So we did that, and then we further expanded it and ensured that our school resource officers had Narcan kit available, our SWAT team members, our traffic unit, our civil process deputies, and we created this Narcan kit ourselves, and what it includes is obviously the optimizer, gloves for our first responders to protect them. And what we also did is we want to make sure that the Narcan kit is always available, specifically the optimizer. And we have this, and the optimizer and the gloves. The optimizer is placed in here with the gloves and placed in this box. And it is put in all of our patrol units. And it also has a carabiner. The carabiner, we attach the Narcan kit to our AEDs. We have AEDs in all our patrol units as well. So to date, we've had a total, so if we implemented the program, 6 what we call saves, 5 out on patrol, and then 1 out in our detention facility. So it's been a very effective program. Going back to the detention services unit, in 2016, we provided 204 of these to inmates. And in 2017, the first 4 months, we've provided 49 intranasal optimizers to inmates as well.
As I mentioned earlier, if you could just comment on the type of usage the locked drug take-back boxes have been receiving in your department and throughout the county.
It's been very effective. Since July of 2015, the Sheriff's Office placed a drug drop box in our Sheriff's Office headquarters, 13101 East Broncos Parkway. Anyone at any time during the normal business hours, 7 a.m. to 5:30 p.m. Monday through Friday, can enter our lobby, go through our security, and go directly to a drug drop box that we have in the lobby. We don't ask any questions. What we do is we do have some instructions that are posted that look similar to this. Things that we will accept and things we will not accept. On average, since we implemented the program, again back in July of 2015, on average we accumulate about 15 to 20 pounds of product per week, quite a bit. It's a great program. Further is the Drug Enforcement Administration annually has National Drug Take Back Day. We participate in that, definitely support it. Most recent Drug Take Back Day was April 29th of this year, and we had 3 locations in unincorporated Arapahoe County and City of Centennial.
Thank you, Louis. I think that this is just one example of what we can do to help A, get the drugs off the street, and B, more importantly, save lives. Narcan or naloxone is an antidote that has been used very successfully throughout the county, currently throughout the county, thanks to the efforts of the sheriff and the sheriff's department and all our law enforcement agencies. Prior to 2016, there was nothing we could do. Now we're there to save a life and get them to emergency medical care right away so we can save their life and hopefully get them into programs that'll help them reduce it. Next, I'd like to introduce Leslie Winter from the medical director of the Aurora Mental Health Department, and to talk about some of her programs and the commitment that Aurora has to dealing with this addiction problem.
So I can shout or I can steal one of these. Thank you. So I'm Leslie Winter. I'm a medical director at Aurora Mental Health Center and also Asian Pacific Development Center. And then also the Crisis Community Connection, our areas. 6 mental health centers came together and bid on the statewide crisis services and we're successful. And so I'm also the medical director of that organization. There are so many programs that are helpful, but the number that is really important is the statewide number for people that are suffering from mental illness, substance abuse, any kind of problem like that. And we have some of the handouts in the back that have that number there. Yep, like that. Exhibit A. Nancy, thank you. So we like to treat people after they've had the kind of experience that this individual had. One of the problems is that when people, so first of all, part of their brain is fighting the other part of their brain. They don't necessarily want treatment sometimes. When they do get on board with treatment, people sort of have a sigh of relief because now they're in treatment, it feels like things are going to go well. That actually secretly is the most dangerous time, because if you're habitually using opiates and then you stop using them, first of all, you get accustomed to them as you use them, and when you stop using them, your body resets. And if what you thought was this amount of substance is what you need to get high, if you go back and do it again, it can very well be a lethal dose. So one of the cool things that came out that is similar to this, so I don't know if you guys know what naloxone and naltrexone and Narcan are, but the opiate receptor is like a baseball glove. And the Narcan, naloxone, et cetera, is like the ball that goes in the glove, and that triggers the rest of your cells to handle pain. And pain is a really big deal, so it can be very addictive, obviously. Even people that have just had procedures can get pretty addicted to it. But once people are off of it, we do now have a long-acting injectable, so it lasts for a whole month. So folks of the same thing, so it blocks the receptors so that the opiates can't affect the receptor, and so it effectively it annihilates the effects of the opiates. So people only have to be interested in not using opiates once a month, which is much more likely than if they need to not be interested in it every single day for a really long time. So for family members, for people that are concerned about loved ones or people that they know, one of the most dangerous times is when they are actually recovering, in early recovery. And so if you know somebody like that and you're able to talk with them about getting help, that is a really good time to be getting help. Obviously, it's a very chronic illness. People relapse 40 to 60%, but which is actually about the amount that people relapse if they have other chronic illnesses like diabetes, hypertension. So it's not completely out of the norm for a chronic illness, but people keep devising cleverer and cleverer ways to grab parts of your brains and hang on to it, like opiates and benzodiazepines and things like that. So we have to continually fight against people using our brains against us. Not fair.
Thank you. Dr. Douglas, he'll give us a lot of frightening statistics.
Bill, do you want me to talk about statistics first? Would that be helpful?
Whatever you want. It's your opportunity.
All right, fine. Introductory statement. So I'm John Douglas. I'm the Executive Director of Tri-County Health Department, which is the health department for Adams, Arapahoe, and Douglas County. And let me say that although the opiate epidemic is unquestionably one of the biggest public health challenges we face right now, we, like other health departments, were not really very engaged in this until Commissioner Holan, Commissioner Mauricio in Adams County began to ask us to come to the table and work with them. Huge opportunity for us, and frankly, I'd have to say, somewhat belated. Our efforts in this area have been largely focused on youth prevention work. Commissioner Holan mentioned that. We work with coalitions in all of the counties that we have jurisdiction over, as well as in Aurora. We also are active in working with others on public education, provider education, working with our colleagues in law enforcement around the access to naloxone, and the public, since Colorado passed a law several years ago that allows a standing order to be created and available. So anybody who's got a loved one who's using an opiate and they are worried about a possible overdose can go into any pharmacy under a prescription written by Dr. Larry Walk, the head of the state health department, and get naloxone. So it's the barriers for using it have been quite reduced. And then as a health department, we are eager to work with partners such as Aurora Mental Health around what is frankly at this point in time insufficient treatment capacity in Colorado. It's tough to get people into treatment. This is a chronic illness, as Leslie said, but we don't have enough capacity for it. I was meeting with Senator Gardner's staff earlier this afternoon discussing what's going to happen federally with the American Health Care Act and making sure that substance abuse, which is currently considered an essential health benefit, if I'm ready for treatment and if I have Medicaid or I have an insurance policy, I can get it now, stays that way. We do not want to regress in that regard. Bill, thanks. We're delighted to be part of the work that's going on in the community together.
Before we move on, I neglected to introduce Judge Corey Elcock from Arapahoe County Drug Court. Could you stand up? She's done a terrific job in helping addicts get out of criminal problems and find ways to non-addiction. So thank you very much. Next, we have up last, but unfortunately, in many cases, she is last to see these people who suffer from addiction, and that's Kelly Lair Cowell, who is a Arapahoe County Coroner, who has worked with us for the last 4 years in really helping us identify what's happening among our youth and our elder population to be the last stopping place for people who are addicted to drugs and don't seek help.
Thank you. So I'm Dr. Kelly Lear, like Commissioner Holland said. I'm the forensic pathologist and coroner for Arapahoe County. And yes, I bring the bad news and the not so positive things to most of these meetings, but that's why I feel it's very important for my office to be involved. We see the end-stage effects of these chronic illnesses. Sometimes we see more acute phases where people are moving from their prescription medications to heroin, and that's been a trend that we're really watching very closely right now. We really peaked as far as the overdose deaths, really peaked in 2009. That was our really big, first really big year of seeing a lot of prescription overdose deaths and overdose deaths in general, also related to illicit drugs. We've really leveled out since then, and we're really following the population growth now. Part of our concern is that we in Arapahoe County and Colorado in general tend to lag behind what's being seen in other parts of the nation by a year or two, and the coasts are really seeing a huge increase in prescription medication deaths and heroin and illicit fentanyl-related deaths. There's a lot of huge problem in a lot of jurisdictions on particularly the East Coast. So we're really anticipating that to be seen here in the next year or two. Right now, we're seeing an increase in the heroin deaths, and that's something, as we've touched on, is that people get addicted to their pain medications and then are switching over to heroin because it's cheaper and in some instances easier to get. So we are following that closely. Our heroin deaths doubled from 2015 to 2016. That is an unfortunate trend and something that we're hoping to address as well by addressing the prescription drug problem. But like I said, what I kind of bring to the table is the statistics and the numbers and what we're actually seeing on the street as far as what's killing these people, what's causing these deaths, and who it's affecting. But that's why I do feel it's important to recognize and for us to be involved and do what we can to help promote these prevention efforts.
Thank you, Doctor. I'd also like to recognize Sarah Erickson, who is here representing the Juvenile Diversion Program. You want to stand up, Sarah? I think that point really emphasizes that this is really a community effort. A lot of agencies involved, a lot of people who are concerned, and what we're asking is now to get help from you in the community. You can identify some of these issues, and we will provide later on some information on resources that are available to families who are concerned and need specific help. At this point, we're going to turn it over to Commissioner Jackson and I are going to go back and forth with some questions, and then we'll open it up to the audience for their specific concerns. Nancy?
Yeah, thank you, Bill. I just want to say welcome, everybody. I see a lot of very familiar faces here tonight and a lot of new faces, so I'm glad to see both, all of you. This is a really important topic, and we're glad that you're here to show your interest and your concern. So we have some prearranged questions that we'll be asking. Bill and I will alternate asking our panel here, and then hopefully we'll have about a half an hour for your questions. Again, we are live streaming, so if you have a question and you don't want the public to know about it, just don't look at the cameras, okay? Okay, thank you. So my first question is, and it's partly been answered, but is this issue new in our community? Someone earlier mentioned that they didn't even know until very recently that this had been going on. So can you speak to that and how it's changed? So talk a little bit about, if you would, as far as your various jurisdictions go, the history and the extent of this problem.
So I guess I'll go, yeah, we can go backwards, work our way back across the table. As I've already kind of mentioned, our deaths, historically, again, it's relatively new. We peaked in 2009, but a lot of the public acknowledgement and seeing this issue has been more recent than that. Obviously, I see things a little bit earlier, and it doesn't become as much of a news story right away. The thing that we have been seeing is the difference in the age ranges that this is affecting, and really what we see is that this is now a problem that spans all ages, from 20 to 60. Pretty much all of those age groups are evenly distributed as far as the prescription opiate-related deaths. So we're not seeing it clustered in one age group as we used to. You know, it used to be kind of a younger, you think of that with the 20 to 30 age group. Now we actually see our biggest number in the 50 to 59 age group, but that's not really statistically significant because they're all very, very similar across all those ages. The other increasing trend that we're seeing, as I discussed, was the increase in heroin, and that's something that we've really just seen a spike in over the past year or two, and something that we'll continue to monitor and I expect we'll continue to see.
You know, I would just echo Kelly's remarks. We're particularly worried as we are seeing this, I hope, continued slowing and maybe even reduction in the hospitalizations and deaths related to prescription opiates, better education, a prescription drug monitoring program, physicians hopefully prescribing more appropriately. We are beginning to see that curve. And frankly, the expense of the drugs on the black market are probably reducing that as well. On the other hand, we have cheaper illicit substances, heroin, much of which is spiked with fentanyl, an agent that is actually used for anesthesiology. It's a sedative, although it's a very potent opiate. It's 50 times stronger than heroin. Is increasingly showing up in illegal batches of what are presumed to be heroin. Its greater potency creates greater risk for someone who thinks they know what their next high is going to be like. But if it's spiked with fentanyl, it can be a whole lot more serious. It's also, and I'll be interested as to whether Under Sheriff Pereira wants to comment on this. He mentioned the gloves his team uses. Part of that is for bloodborne disease prevention, but part of it is increasingly a concern that getting fentanyl or strong substances on the hand or ingestion could be an issue as well. I think it's useful to sort of think about this from a comparative perspective. When I first heard about the opiate epidemic from the director of the Centers for Disease Control, where I was working at that time, I mean, not first heard about it, but first became aware of what an enormous issue it was. The comparative statistic that Bill cited, it's more than car accidents, was just incredibly staggering, because we used to talk about how more people die in car accidents than died in Vietnam. That's what I learned when I went to medical school. And now we've had this eclipse of that with this new and dramatically growing problem. My own personal background is in infectious diseases. I grew up as a physician taking care of people with HIV infection. And it was, again, staggering to note that the degree of the epidemic that we have now, somewhat curbed, but still with us, has actually eclipsed the number of deaths per year in the country than we saw at the height of the AIDS epidemic. So this is not just a relatively bad phenomenon, it's an absolutely bad phenomenon. I guess the last thing I would say is that most of us in this room are Caucasian. And I think there's been a notion that drug use, heroin use, is an inner city problem. That's who's using it, that's who's dying. That is absolutely not what's going on with this epidemic. When we look at the demographics of people in Colorado or in Arapahoe County, a much higher proportion of those dying of heroin and prescription opiate overdoses are white than in the general population. So this has gone out of what we stereotypically think as those people who use those drugs into, as Kelly said, a very broad phenomenon.
Any other comments? I'd like to recognize one of our other county commissioners who just walked in, Kathleen Conte, who has been she's brand new, but she's came into this supportive mode of our efforts and has some personal anecdotal stuff to talk about too, but we welcome you. We want to thank you for your level of commitment.
We also want to recognize Representative Mike Weissman, who's here,
yeah.
Colorado State Representative. Thank you.
You blend into the wall so well, but sorry, apologize. This probably is directed more at Dr. Douglas, and that is, in your analysis of the statistics that you monitor, part of your responsibility, are there specific patterns or differences in demographic, education, economic status, and gender opiate? You touched on it briefly in your last response.
I'd say the striking thing is, as Kelly said, this was drug overdose issues were typically thought of as being a younger person sort of thing. And that's one of the striking parts of this epidemic is how broad it is in terms of ages. So that's point number one. Point number two is the racial, ethnic distribution of this, as already mentioned, different than drug epidemics we've seen in the past. The third thing I'd point out is that this is, again, not a inner city problem. This is not downtown Denver just, although it's happening plenty down there, or just downtown Aurora. This is happening in our suburbs. This is happening even in our rural areas. And in fact, our rural areas on a per capita basis are actually harder hit than any other area. When we do sort of density maps or heat maps to ask where's the problem happening, we see it, again, spread out in most parts of certainly of Arapahoe County as well as the metro area. So it's geographically spread, it's age-wise spread, and we have a spread involving a variety of different racial and ethnic groups.
So I think that's one of the issues that I think has generated interest amongst politicians, and particularly with regard to when suburban housewives are laying on the floor dead, all of a sudden there's an interest to deal with this issue. And Nancy, do you want to with the next question?
Okay, so this is something I'm interested in. I'll probably tell you a little bit more about the things I've been involved in lately, but as the undersheriff can tell you, I've been quite involved in our criminal justice system and mental health issues. So here's this question, and I think it might be an interesting conversation to hear what your perspectives are. So would it be more helpful to have more stringent sentencing laws, or more diversion to treatment programs? So what works better, what's more effective, putting folks in jail and punishing folks, or sending folks to treatment?
Well, first of all, I need to understand that as a law enforcement official, my responsibility is to enforce the laws of the state of Colorado and federal laws as well. So with that, obviously I have an obligation, and that is if we come across someone who does have illegal drugs and we have probable cause to arrest, we must effect an arrest. With that, do I believe that more stringent drug laws, that we need more stringent drug laws? And, excuse me. Can you hear me? Okay. I don't believe so. You can look at our history, and it has not been effective. We spent millions and millions, probably billions of dollars trying to address the drug issue, and look where we are today. It is an epidemic, and it is an issue that unfortunately...
We've got our
Thank you.
8.
And my belief is that we need to provide more treatment. We need to keep these individuals out of jail if we can, get them the help that they need because it is sustainable. Some things the sheriff's office has done, although again we have an obligation to arrest, it just doesn't stop there. We also have a detention facility. And since 2012, we've been seeking grants from Office of Behavioral Health in the state of Colorado, competitive grants to get to JBBS, that's jail-based behavioral mental health system, into our detention facility. And over the years, we've received hundreds of thousands of dollars. And where does that $100,000 goes? It goes back into providing treatment to our inmates. We have a collaborative effort with our mental health professionals to address mental health issues and substance abuse. Therapists are brought into our detention facility, and they do assessments on our inmates that want to participate. We have great participation. Also, they do individual therapy sessions, group therapy sessions, and then develop, if need be, some reentry programs as well. And those have been very effective, and we need to continue to do that. But the unfortunate thing is the dollars that we were getting years ago are starting to shrink, and it's going to have a domino effect. And my thought is we either pay now or pay later. Let's try to address the root of the problem, and that is providing them the necessary therapy that they need, hopefully that they can overcome their addiction.
Thank you very much. I would only bring your attention to the front page of the Wall Street Journal today. There's an article that's headlined, "Opiate Makers Sued for Stoking Addiction." And it's the Attorney General of Ohio is suing several of the major drug manufacturers in the state of Ohio for their blatant disregard for helping promote the opioid drugs as non-addictive. So that'll be an interesting case to follow. The next question is, and this is directed to Dr. Winter, can you please describe the connection between substance abuse and mental health?
Keep it away from me.
Okay. Actually in the DSM, which is our Bible of not drug problems, but mental illness, substance abuse is a large portion of that. So we do consider that as part of our scope. In the past, there's been more siloing where substance abuse has been treated over here and mental illness has been treated over here, and there's much more of a interaction between them. Aurora Mental Health Center, we are now taking over a detox or withdrawal management facility and doing a lot more with substance treatment even of folks that don't have mental illness, but it certainly is exacerbated by people that have mental illness. It's a very tough problem, and if you don't treat the mental illness, it's really hard to get the people interested in doing this substance treatment as well, because they're in pain emotionally and physically, and
I was just wondering if we could follow up with Undersheriff and talk about how many, or maybe Dr. Winter, you could speak to it too, about the dual diagnosis and what happens when somebody self-medicates.
right. So even if people are self-medicating initially for any of the illnesses, anxiety, pain, once the drug gets a hold of your brain, it really does actually change the pleasure centers in your brain so that it's hard to get off of it. So even if the mental illness is the primary thing, once people start using substances, it becomes a dual diagnosis, and it really does have to be treated together. And just a plug for exercise. It turns out part of the thing that you miss in your brain is brain-derived neurotrophic factor. So if you exercise, it actually really helps a lot for people even who are trying to withdraw from opiates.
Good. I'll talk about another program the Sheriff's Office does have. It's called ADMIT, Arapahoe Diverse Mentally Ill for Treatment. And this is a program that we've gotten support from our county commissioners for at least a decade. And what it is individuals that are brought in detention facility, if they meet certain criteria, that they're dual diagnosed mental health and drug abuse, and they meet certain criteria, they're put into this intense program. And it's been very, very successful over the years. I just want to thank the Board of County Commissioners for continuing to support the ADMIT program, because it has been extremely beneficial to our inmates.
Yeah, and I think that brings up another issue about folks that have been incarcerated. We've done a lot of work with the systems in making sure that, so we have people that go to the jails and prisons that are our therapists, but also we send our electrons telepsychiatrically in and meet the folks before they come out so that they can transition out and be on medications. Because one of the problems when they come out is if they get lost to follow up, then kind of all bets are off there. It increases the risk of both mental illness and causing troubles in the community.
And if I could add one last thing, one thing that we do at the Sheriff's Office as well, when an individual is released from our custody and they are on a prescription medication, generally what happens when they're released from custody, they no longer have Medicaid, Medicare. They need to start that program again, and by the time they get their medication, get back on it, unfortunately, it's a process where they need to start over. So one thing that we've worked with our medical vendor is that when they're released from our detention facility, we give them a 30-day supply of medication to hopefully bridge that gap.
And hopefully we have somebody from Human Services there also to help get them signed in for Medicaid as well.
Yes, we do.
Yes.
Yep, okay. So now that we're all depressed, what options do we have in our community for treatment and recovery? And anybody can take this, other than, I'll put in a plug for Rocky Mountain Crisis Partners, 24-hour, 7 days a week, rain or shine hotline, where whatever kind of issue for whoever it is that you see, you can call and they will triage, that is, they will help you solve the problem immediately and then hand you off, or the person who calls off, to the appropriate agency for follow-up. So just want to put a plug in for them, and then open it up to the panel.
And then there's a lot of entries into the various systems. There is a detox center on 6th and Potomac, so if people are actively using and need to detox, that's one option. We also, the Crisis Community Connection has 6 walk-in centers throughout the Denver metro area. And then we have a crisis stabilization unit, and we frequently have people who are withdrawing from substances, and we give them support, not the medication-assisted treatment, which you may have heard about, which is Suboxone, but other kinds of support as they're coming off of the medication. There are medication-assisted treatment programs as well throughout the Denver metro area, and then mental health treatment. So there's the Rocky Mountain Crisis Center is a good way to get into the system, but also you can just walk into any of the walk-in centers. And Rocky Mountain Crisis does actually talk with parents and family members too. You do not have to be the identified patient to talk to them. One of the problems with this is that it affects a very large swath of the community, right? So it's the person who's affected, that's a problem, but also people around them can feel really frustrated. It's hard when it, with an epidemic of flu or whatever, everybody's on the same page. We all want to get rid of the flu. When it's your brain fighting yourself, it's much harder. Sometimes the patient doesn't want to be involved, and so it affects the family members, I think, a much harder, and they don't really know what to do. And so also treatment and help is available for family, friends, teachers, anybody who's needs to talk to somebody about somebody they know.
Thank you. I think that we've answered the next
Oh.
question, is that how should family members or friends do with someone they know needs help? Well, start with the crisis center call, and they will identify where you can go. Nancy?
So, other than the crisis centers, what can our citizens, so we have a lot of folks here in the room, for example, who want to get involved, who want to do something to help. All four of you have help in various different aspects. So what can our citizens do to help with this terrible public health problem?
I'll go ahead and start. I think it starts in the home, and what you need to do is, several of us have prescription drugs in our medicine cabinets. We need to get them out of our medicine cabinets if they're not in use. If they're there, somebody who is not authorized to use them is going to use them. They're going to experiment with them. That's why the Sheriff's Office made available the... Sure. Is that better? Yeah, we need to get the prescription drugs, unused prescription drugs out of medicine cabinets. If they're in medicine cabinets, somebody who is unauthorized is going to use those. You're going to have kids, family members see those prescription drugs and use them, abuse them. Also, in what the Sheriff's Office has done with the drug drop box, supported the National Drug Take Back Day, and we need to dispose of them properly. Unfortunately, many times, if there are prescription drugs, if people want to get rid of them, what do? They flush them down the toilet. We don't want you to do that. That's an environmental disaster. So do not flush them down the toilet. Contact your local law enforcement agency. You can contact the Sheriff's Office. You don't have to be a citizen of Arapahoe County. Anybody can stop by and use that service that we provide. Again, Monday through Friday, 7 a.m. to 5:30 p.m.
And
Yes. And I know recently Walgreens at all of their stores now have drug drop boxes as well.
I'd also like to add that if you had a gun in your home, you would lock it up. You could lock these up. It's more dangerous right now than guns, and kids, not just kids, all people who are having this issue of fighting themselves will do things that they wouldn't normally do. If they come over to somebody's house, they will look through their cabinets to find the drug that they're seeking.
And if I can add to that, as far as securing those prescription drugs, many times we've received numerous calls, homes for sale. Somebody will go in and look at the home. They'll use the restroom, and what are they doing? Are they there and looking to buy a house? No, they're looking to get some drugs. So make sure you secure them as well.
I might chime in. I couldn't agree with Under Sheriff Perea more. This begins at home, although one thing I'd emphasize, it begins at home for those of us who have kids as parents, because much of the introduction into activity that ultimately can result in misuse of either prescription or street opiates begins in youth. That's one of the reasons that the Office of Behavioral Health has worked with health departments such as Tri-County to develop, one of the reasons the Office of Behavioral Health that Under Sheriff Perea mentioned has developed substance abuse prevention programs in each of our counties. A big focus of this is parent awareness and parent engagement. It's a lot more than just say no. It's teaching kids skills about what to do when they encounter drugs, learning how to get themselves out of situations, awareness about what kids are doing. I mean, this is old stuff we've been hearing, but it's super relevant to the epidemic that we're dealing with right now. Leslie mentioned that exercise is good for everything. School involvement, if you're a kid, is good for everything. Being involved in extracurricular activities, parental encouragement, even if you're not going to be the valedictorian of your class, in academic engagement and success. These are hugely protective factors that not only help kids in high school, but help kids as they become young adults and beyond. And so that beginning, if you will, is, I think, really critically important. I guess the second thing I'd mention is that most of us, if we dig hard enough, have either a family or a friend or a neighbor who is dealing with mental illness or substance abuse. And this point that was made earlier about this being a chronic illness, I cannot emphasize enough. A huge part of the problem we have in dealing with this as a public health issue, or really as a treatment issue, is the stigma surrounding these issues. We don't like to talk about mental health issues unless you're a professional. We don't like to talk about substance abuse issues. We like to sort of put it in a corner. And so I think this, we're conducting a campaign right now as a health department in collaboration with about 270 partners across the community around mental health stigma, getting all of us to talk about this more. The campaign is called Let's Talk Colorado. And so I think that recognition that these behavioral health issues are as integral to overall health and therefore as worthy of attention as getting your diabetes treated or getting a new joint if you've got arthritis. This is bread and butter part of health. So, and that's an every one of us sort of issue.
And as an interested professional, it isn't surprising that brains have lots of things that cause trouble. Your heart is actually a pump, which is fairly simple. I mean, it's a very cool pump, but it's fairly simple. Your brain has 80 billion neurons. So to put that in perspective, 7.5 billion humans on the planet, 80 billion neurons in your brain. It's a lot of moving parts. The fact that they go wrong sometimes, get glitchy, is not shocking. The fact that they don't go wrong is pretty shocking. So if you can think of it as, I mean, if we had any mechanical or electrical system that had that many moving parts, we would be very respectful of the fact that things could go wrong with it and not stigmatize it as much. I think when it's, what you kind of think of your essence is how you feel, how you think, you know, if you hear things or don't hear things that aren't there, those feel like a person's essence, and so I think it's harder to talk about it, but it is a system that has lots of moving parts, and so it is not shocking that it has trouble sometimes.
Nancy, I think we've covered question 9. You want to finish up and we'll open it up to questions.
Okay, thank you. Before we open this up to the audience, I was going to speak about this, but I think Mike Weissman, our representative, can speak to this issue. So I'm going to give Mike the mic for a few minutes to talk about what our legislature has done this year to really play their part, step up to being helpful with this crisis. So Representative Weissman has just a few minutes of time.
Thank you. I'm the rare elected person who doesn't do a good job talking loud, so this probably is for the best. Thank you for giving me just a sec. Again, I'm Mike Weissman. I represent House District 36, which is just the other side of Chambers here, and I wanted to come tonight to support what our commissioners are doing and to be able to say a few things about what the state legislature has been doing. This is not just a county issue or a city issue or a state issue. This is an all of us issue, and the opioid subject got a lot of attention at the legislature this year, as it should. So I'll just briefly touch on a few things. I'm going to say some bill numbers, so if you're interested in all the details, you can go to the legislative website and look them up by number, and we can talk after if you'd like details on that. So the first three are passed by both chambers. They have been signed by the governor or will be signed. House Bill 1351 is a study of inpatient basis treatment for addiction in the Medicaid system. Senate Bill 74 is a pilot project in Pueblo and Routt counties. Specifically, as we heard, this is an issue that is disproportionately hurting rural Colorado, and often those counties have even fewer resources proportionate to the problem than we're fortunate to have here in Arapahoe. So that's why the focus on those two counties. Senate Bill 193 is to create a new research center into the science of addiction and so forth at the Health Sciences campus just up here on Colfax. A fourth bill, 1350, House Bill 1350, would have allowed a prescribing pharmacist or a dispensing pharmacist really to issue less than the full prescription. So there's fewer pills floating around. For some reason that I'm not sure about, this was defeated in the Senate, although it seemed like it was reasonable policy to me. Two other things, because they kind of came up. The issue of mental health holds because of how substance and mental health issues intersect sometimes. The governor vetoed a bill on this last year because he did not like the approach. The issue being some particularly smaller counties, there's not capacity to properly house somebody in the middle of a mental health crisis. So a lot of times a jail or criminal type of situation is used, and that can often make the problem worse. We passed a bill this year to really get away from the criminal approach and treat mental health hold needs more like what they are, which is a medical, psychological situation and not a criminal one that could have some intersection with opioid addiction issues, as our panel discussed. Finally, almost finally, there was the subject of, do we take more of a crackdown, tough on crime approach or treatment? There will be an interim committee that will meet 8 times over the course of the summer and the fall. Details will be coming out from the legislative website shortly to look at criminal sentencing issues, including things like aggravating factors, mandatory minimums, not quite everything under criminal sentencing, but some of these additive or multiplicative factors, and that may touch on things related to drug sentencing. And I saved the best for last. There will be another interim committee specifically to study opioid issues and policy solutions. A lot of folks here are probably already familiar, but in 120 days, the legislature maybe does 700 bills. It's not necessarily the best way to really get in depth on an important subject. That's what an interim committee is for a group of folks who are appointed by both parties in both chambers. So these are bipartisan, bicameral committees to really go in detail. There's always a bunch of different requests. Leadership kind of narrows it down and decides what's really important in Colorado right now, and the opioid issue is one of those. So appointments are going to be announced very soon, maybe as soon as tomorrow. It should certainly be out in the press by next week. This particular committee is authorized to meet 6 times over the summer and fall and to put forth to the 2018 legislature up to 6 different bills. Sometimes it may happen that a particular issue that was discussed doesn't have majority support of the interim committee to roll the bill forward into 2018 as an official interim committee bill, but an individual member can always pick up an idea. An important thing about these interim committees is just like everything else the legislature does, they're open meetings, they are public. So you will be able to go down to the Capitol if time and life permits, listen in, sign up and testify. There will be streaming audio like there is for all of our regular session if you want to follow along that way. It sometimes takes a few days, but they get the archive of the audio online, so if you want to catch up, you can do that. And watch what members are going to be appointed. Contact them, let them know if you have an interest, even if they're in a different county, if they don't represent you. They're working on this issue, and we all kind of represent all issues and everybody up there. So I think this is a really good opportunity to go into depth on some of these issues that we're talking about here.
Thank you, Representative. Okay, now we're going to open this up to our audience if you have questions. If you would just, is that Ken? Okay, Ken, I think I see you first.
We'll get you a mic,
Wait,
Ken.
yeah, wait for the mic, please, so everybody can hear. Thank you.
I would like to ask about the money issue. Undersheriff talked about a little bit. I'd like to find out, county commissioners and the legislature, are you working together to fill the gaps money-wise?
Ken, could you explain what you mean by money-wise? I mean, clearly, we are all working together. We have
Well,
really tight
the
partnerships.
undersheriff mentioned that we're not getting as much money
So
as we
you're
used to.
talking about money for treatment?
Yes.
Okay, so where does the money for treatment come from, and do we partner in that? Is that what you're, okay.
Well, I can just say from the county's perspective, we've aggressively supported these programs that come forward. However, majority of the funding that comes for drug treatment program comes from the federal government, from the various departments within the government, the Department of Justice, the Health and Human Services Department, and many, many other federally mandated programs. The county is required and responsible for providing some of the funding for those programs, and we will continue. The large concern, which is very impactful on all sources of income, is the current recommended budget from this administration, which would eliminate many of these programs and ultimately make the problem worse. I think that we need an effort of collaboration, and we are collaborating between all these agencies to help them to the degree that we can, to consolidate resources, to be able to ensure that the people that are suffering from both mental health and substance abuse problems have available treatment modalities that they can get in. But it's going to require an effort of collaboration both from the federal, state, and local governments.
Dr. Winter, do you want to add to that, or?
Sure. I do think in some ways we're really lucky in this state in that the crisis services has really been beefed up. And so far that hasn't been taken off the table, so that's really good. We do have some problems with getting people inpatient, so some more funding for those kinds of services would really be helpful. But again, it's very tricky because there's not, I mean, the crisis services is actually something that our state has done separately, but a lot of the funding does come from the federal government, and we don't have control of it.
And the funding that I was talking about, first of all, Arapahoe County has been very, very supportive of all the programs that we have in the detention facility that support mental health and drug abuse. Again, with the admin program that's been around for well over 10 years. Again, the Board of County Commissioners have supported that and funded it appropriately. What I was talking about is the Office of Behavioral Health. About 3 years ago, it's a competitive grant, it's a statewide grant, and we received just over about $500,000. Today, we're about $350,000. What we continue to do is we always look for opportunities for grants both at the state and federal level. Those are, again, very, very competitive. We'll continue to complete the proper applications and hopefully continue to get grants, but we're always looking.
So I just want to say, and then we'll get to you, that both our Sheriff's Department, Aurora Mental Health, and we have someone here tonight from All Health Mental Health Network, which is the Arapahoe Douglas, the southern part of the county mental health organization. They're very aggressive in getting grants. So there is a federal, it's called SAMHSA, substance abuse. They have a lot of grants, and our mental health centers and our sheriff's office are very aggressive in looking for those and getting them. So it's really terrific. Okay, in the black and white, way in the back.
First, I want to say thank you very much for coming and having this town hall. And I want to say thank you very much for the people who are working in law enforcement in the court system. I am actually a licensed addiction professional and a licensed mental health counselor. So LAC, LPC, acronyms, I've got a lot of them. I have a few questions, and I'll sit down. just taking some notes off of what you're speaking about. My first thing is that as a professional, I heard you speak about family members and loved ones that can go ahead and get Narcan. I, on 2 occasions, have tried to go ahead and pick up the Narcan for my private practice because I go and visit people who are in crisis. Unfortunately, when I looked to go around to get it, I had to use my personal insurance for this, and that's not appropriate as a professional. I should be able to go in there, and I want to say thanks to the doctor who's writing out the general prescription for that. The second concern with this is that the 2 large grocery store, Target and King Soopers, they had a huge disparity in price. So again, if it's this way for me as a professional, I just believe that it should be a lot easier for family members and friends and people in the community to come and get that. I received my training in the Narcan from the VA hospital, the videos that they sent, and they were excellent. But I'm not seeing that out in the community for everybody to go ahead and education and to learn, and that's a really big part. One of the second thing I wanted to say is that the pharmacy requests ID for controlled substances. So that's anything from Adderall to, which is an ADHD drug, to opiates for your pain pills. I'm wondering with this is that could there be a stronger than a recommendation? Could there be a mandate for doctors to go ahead and have somebody in their practices educate their patients on the use of the meds that they're going to be receiving, the prescriptions they're receiving? Just recently, I had a personal experience with this. Somebody in my family had to have surgery and was given benzodiazepine and Percocet. I'm trying to think of which one it was, and a couple of other antibiotics and everything. The only person that sat down and talked with this person about how to take these drugs was the nurse in the recovery room. And again, I'm an advocate, so I was with this person, and I'm thinking, wow, first of all, and she wrote it down, which was lovely. I said, I need to stand up and give you a hug because you're the first person that's actually sat and discussed how to take these drugs. So, but then I also thought, yeah, that's kind of the last place you want when you're totally groggy. So if that could be a suggestion to have more education. And sir, yes, you, right there in the blue tie. We talked about, you talked about a couple things, jail or treatment options. Okay, so I come from unconditional positive regard. I recognize the whole idea of discipline versus punishment. And the commission, there was a commission several years ago, and I think it's still around, the Commission for Criminal and Juvenile Justice. I'm wondering how that commission is looking at substance use disorder and mental health issues. And that brings me to my next thing is that if we can, as a community, can do just little twists of our words that we can go ahead and make, instead of having a stigma of mental health, or excuse me, mental illness, to say, you know, that's a mental health and wellness issue. That's a substance use disorder instead of saying abuse. Because when we think of abuse, we think legal. There's something going on with that. Let's see, I just want to make sure I got this and then I'll sit down, I promise.
I think it's going to be hard for them to answer all of those
And these are things to think about. So, you know, you don't have to answer it like right now.
They're
Absolutely. Jail or treatment options. I have several people that I work with. Unfortunately, when we come into the court system, there's not room for them. They can go, they're free, but then they relapse or they pass. And that's something that if we could go ahead and a bit more education and more the treatment options, not just have a space for 30 when you have thousands who really need that.
So later on, when I do my summary, I'm going to talk about what we are doing in Arapahoe County about mental illness, mental health, and the folks that are familiar faces in terms of mental health and other kinds of things. But I'm going to ask the sheriff, undersheriff, and perhaps some of the physicians to address those other issues. I do agree that those are really very good things to think about.
Sure, as it pertains to treatment in a detention facility, and the unfortunate thing is the 18th Judicial District, it's the largest judicial district in the state of Colorado, has over 900,000 citizens that live within that judicial district. Specifically in Arapahoe County, we understand that there's a need for more space in and around courthouses to provide some treatment, some therapy, some interaction. I can't speak for the courts themselves and what their plan is. That's something that Chief Judge Samore would have to answer for you. But from Sheriff's Office perspective, our space is very limited as well. We're very fortunate that we have a program in the Sheriff's Office. It's called the RISE program, Restoring Individuals Safely and Effectively. And this is a program that we started about 3 years ago. And there was overcrowding in the state hospital for mental health. And myself and Commissioner Jackson went to California to see a program there, Restoring Individuals Safely and Effectively. And what it is it frees up bed space at the state hospital because there is such a long waiting period. And as you know, once an individual commits a crime and there's a question of insanity, it takes a long time for them to get to the Colorado State Hospital. This RISE program in the Sheriff's Office, we work with a local vendor and also the State of Colorado Office of Behavioral Health to get this, that brought this program to the Sheriff's Office. And what it does is individuals where there's insanity that's in question, and there's a likelihood that with a little bit of therapy and treatment that they will become competent to stand trial. So we bring them into our facility, and the turnaround is remarkable. It's about 59 days on average as opposed to the state, which is almost twice that, and the cost is considerably less. The cost at the state hospital is probably $700 to $800 per day per inmate. Here in our detention facility, it's about $350 to $375, again, with a shorter turnaround. So there are some things that we're doing. We're being innovative, creative, trying to get people to court so that they can get released if that's an issue.
Thank you. I want to acknowledge Commissioner Sharp just came, so one of our fellow commissioners, so good to see you. Oh, yeah, please, Dr. Douglas.
Yeah, I hope this is being recorded because that was such a great set of questions. In fact, I think you ought to talk to Representative Weissman about going to, I don't know if he's going to be on the committee, but it sounds to me like there's some nuggets of policy there. I mean, I'm hearing a couple of things in your questions. First of all, I'm hearing issues about, okay, we've got standing orders that anybody can go and get naloxone, but like almost everything else when you create sort of access, you run into problems. And I heard you mention at least a couple problems, using your insurance for it and differential pricing. Well, we know drugs are disparately priced hugely across our communities and frankly across the world where we pay higher prices than anybody else. And I don't know, I also want to acknowledge Rob Valek, who is here. Rob is an important actor in the state as the lead of the Colorado Prescription Drug Overdose Prevention Consortium. And Rob will be intimately involved with the new prevention center at Anschutz that was mentioned. And Rob, I don't know if you heard these really good questions, but it gets to do with now that we've got greater access to naloxone, what are the barriers to its use and how could we better study, understand, and remediate those? The second point I heard you say was training about use of naloxone, and that falls into that same camp, as well as education for people that are getting drugs. Your anecdote is spot on. When I was in a recovery room 6 weeks ago, that's when I got my instructions about using Percocet, and I was worked out. And if my wife hadn't been sitting there taking notes, then we wouldn't have gotten it. So that's, as Nancy said, I think that's incredibly good food for thought. And then finally, I think your point about the use of language and how we use it carefully and how we avoid things that are stigmatizing is, I don't know that we need a statute to address it, but it's a great reminder for all of us.
I just want to say to another of your points, you gave us lots to think about, so it was really very good, is that our sheriff is on that state committee for criminal justice reform, and he does help with the behavioral health issues. So they are active, they are working on it, and it's just, like I said, I'm going to talk about it a little bit when I do my summary, but this is a huge issue across the state and nationally. So there are folks nationally who are working on these same problems. The opioid public health crisis is one thing, but we also have the involvement with the criminal justice system that just makes things even more complicated. Okay, one of our commissioners had a question, and then I'll get to Marty. Yeah.
Commissioner Kathleen Conti, and I'm just curious from our mental health professionals that are here and are dealing with this. We've heard stories about, written in local newspapers, Newsweek, et cetera, regarding marijuana being a antidote, if you will, for this opioid abuse. Wondering if you could weigh in on this and what your thoughts are. Obviously, we've had marijuana now for over 6 years in the state. And according to a recent speaker that I heard, we now rank #1 as far as states in addiction problems in this state. And just wondering if you could weigh in there.
So I don't know if there's any research on this, but anecdotally, it seems like we're having more people with psychosis rather than having people be helped with pain with marijuana. I think, I'm somebody that does not like to try the new medications on patients when they first come out. I like to wait a couple years and see if other people's patients survive it. I think that this experiment that we're doing with brains is really scary. And it turns out you just have the one. So, if the marijuana thing doesn't work out, you can't do the undo button. There's no undo button. So if it were me, I would wait and see how it goes before I started using pot, because they're breeding it very strong. It's not like, I'm older, and it's not like what we used to have when we were little, just a touch of marijuana. This is, that was dachshunds. These are Great Danes, right? So you can breed stuff to be very different than what it was in its original form. And we are seeing I've had many people who I believe that their psychosis is only because of the marijuana. So they're even apparently stripping the marijuana like they do with meth. To me, it's a scary experiment, but free will is hard to manage, but we believe in it. So,
And I'm just wondering, Dr. Douglas, do you have any statistics on the connection between marijuana and opioids?
Not really. I think I share Leslie's concern that this is an explosive and poorly explored intersection. I must say, it's notable to me that Bill read us the headline from the Wall Street Journal about manufacturers of opioids having developed and prescribed or rather marketed medications under one set of assumptions. And of course, marijuana, whose potency is often sold without clear indications, is not FDA controlled. And so we've got, it really is, we're Colorado, we're the West, it's the Wild West in terms of that regard.
well, and I just want to say that word medical that they put in front of marijuana is not an actual medical term. It is not FDA approved, has not been studied. I mean, some of it has been studied in some places, but the stuff that people are getting in their local shops is not a studied medication.
So the research that Representative Weissman was referring to, the money for research is going to be important. Okay, let's go to Marty Carnop, and she has a question in the back.
I have 2 comments and a question. The first comment is I've had a couple of surgeries in the last couple of years, and I was prescribed some opioids, and I used them minimally as I could, but I used them. And then my husband had surgery, and we opted not to get his prescription, just to continue to use mine. I still have half of them left. I was overprescribed, and that bothers me. Ambien is another problem that I've known a number of people who've had accidents that were serious, and I just think it's a crime to prescribe it myself. My second comment is that I've been mentoring at the Denver Women's Correctional Facility, the women's prison in Colorado. That is the largest mental health facility in the state, because 67% of those women have either mental health or substance problems, or both. Also, the first woman I mentored was part of a burglary ring, and they had this burglary ring to raise money to buy drugs. The second woman, she had the problem with Ambien. She had complications of childbirth and was taking prescription drugs, and she took Ambien. She went out and drove her car and actually killed somebody. So my point is that this is not just a public health problem, it's a public safety problem. There would be a number of crimes that were not committed that we would not be victims of if these issues were dealt with. And my question is, about 10 years ago, you used to hear a lot about meth, especially in the rural areas. People cooking meth in their kitchens and ruining their houses and stuff like that. And now you don't hear so much about it, and I wondered, is that included or is it replaced by the opioid problem? I just don't know how the two are related.
So if you have a headache and you hit your head on a brick wall, your headache doesn't hurt as much. I think that's we have a ton of people that have meth that come to our walk-in clinics and to our crisis stabilization units. I think it's still a big problem. It's just that more people are dying from opiates than are dying from meth.
Yes, and that's definitely what we see in my office. We still see plenty of methamphetamine. We see plenty of methamphetamine-related deaths in the coroner's office as well, but heroin obviously has eclipsed those. If you look at our numbers, 30 heroin-related deaths for every 20 methamphetamine-related deaths. So it is still a significant problem. Denver County, as far as their deaths, are seeing actually a spike in methamphetamine the past 2 years, and that's something that they're watching, but it is still around.
Okay, we're going to do 1 or 2 more questions. You have somebody here? Okay, and then we'll get to Carlton.
My name is Janet Bachman, and I'm just an average citizen who has been spending the last 10 years dealing with my husband and chronic pain. So my question is, what's being done to help destigmatize the villainism that has come from people that are dealing with chronic pain? And we've dealt with, and he's off of opioids right now. He's been off for 3 years, but I have to watch him suffer every day with zero quality of life because there's nothing to help him, whether it's medicinally or alternatively. We've tried everything under the sun, and the only thing that keeps coming up is the opioid addiction issue, but it just further vilifies the people that have chronic pain issues, and there's nothing to help them. The legislature doesn't help, because every time we'd go to a pharmacy, you get looked at cross-eyed, you have to give your ID, you might have to give your right arm, and yeah, was he addicted? He absolutely was, but not because he wanted to be, and there was nothing to help him. And it's just gotten worse because there are people that are taking advantage of it, but what's being done for the people that legitimately need help, and there's nothing to help them. I heard you talking earlier about suicide. I could see it in my husband's eyes where he has no quality of life because he's in constant pain from multiple surgeries. And I know, but for his faith, he probably would have taken his own life because he's miserable. So now what do? How do we balance the fact that there are people taking advantage of it with the people that have a legitimate need?
Thank you for sharing that. Dr. Winter, you want to take that one?
Well, that's a really hard problem, right? I mean, if you actually don't have pain receptors, you end up dying usually by age 3, because pain is a very important part of our lives. The reason it gets your attention is because if you didn't have them, you would be dead. But we also have lots of reasons for pain, and it is very difficult. I mean, it gets your attention. There are some groups that can help. So it's like saying, my favorite anxiety thing is, if somebody has anxiety, it's like having snakes on their lap. And it's like me saying, well, yeah, but just don't pay attention to those, right? They're just snakes. And it's the same idea, right? I mean, anxiety is powerful, pain is powerful. These are powerful systems that were built to get your attention, and it is not easy to manage. And I do think that when you add stigma on top of it, it makes it even harder, right? Because then you're having to deal with all kinds of other emotional things that go on in addition to the pain. And certainly pain makes depression worse, depression makes pain worse, anxiety makes pain worse, pain makes anxiety worse. So it is not an easy, it's a very awful thing, and I'm sorry.
Well, we got a bunch of hands up. I think Carlton had a hand up early, and then get some of these folks in. You have a mic?
First of all, a couple comments. Marty, I agree. I had colon cancer, and I was given a big vial, and I ended up throwing 90% of it away. And I do sympathize with the madam over there that said her husband was in pain. It's a problem. And, I'm encouraged to see so many of us here tonight, ordinary citizens that came out. You didn't get paid to do this. And I think we need to go home and think about it, because this is a problem we need to work out. It's new. These new powerful drugs that are super drugs really is killing so many of us citizens. And but I'd like also to talk about we are bombarded by TV ads, a pill for every ill. And with that, I want to comment that I had colon cancer, and I threw most of those away. I had a ruptured disc, and the first visit, my physician prescribed a steroid injection. Then he gave me a bottle of pills, and I only used one of them. And then he scheduled me for surgery. And I don't know which of the panelists would like to address this, but are there has anybody addressed that we are being bombarded that we need to have a pill for everything? And there are alternatives. Like, for example, for my back, I was deferred to go to Robin McKenzie. I did physical therapy. I saw chunks of discs up and down my spine, and I didn't need to have surgery. I canceled my steroid injection, and I only took one pill. And right now, I can jump around, and it's been a year and a half, and I didn't need I think our physicians, is anything being done to train our physicians, like this particular physician? I'm not going to mention his name or what system he was in, but he didn't tell me that there was physical therapy that I could do. So would anybody like to address that, what we can do as our physicians can do besides relying so much on a pill?
Well, we have 3 physicians here, and I'm the one that's probably farthest away from patients, although I guess you're mostly non-living patient, different kind of patient. Let me take a crack at that. I couldn't agree with you more. My own background before I did public health was as an infectious disease specialist. I mentioned my work in HIV, and frankly, a pill for every ill just nails it in terms of how we overprescribe antibiotics, for example. And, most of the prescriptions for antibiotics are for viral infections that do not respond. So yes, now there are proactive efforts within medical training and in postgraduate training to try to train people in what's called antibiotic stewardship. Use the drugs smartly. That's point number 1. Point number 2 is that You know, we have an interesting healthcare delivery system in the U.S. that's been under the microscope lately. One of the issues that we are increasingly aware of is that payment that pays for services, specific services, as opposed to outcomes, inevitably generates more stuff, more laboratory testing, more x-rays, more admissions to hospitals, and frankly, more drugs. We haven't really figured out what it means exactly as a large health system to switch from fee-for-service payment to what are called value-based structures. I mean, there are ideas out there, but I think that will be part of the let's give you an operation rather than physical therapy kind of solution. So I'm a number of years out of medical school, so I'll turn to my younger colleagues.
What a compliment.
I know. Hey, you know, if you hang around with the right people, you're young, right? Okay, so I'm going to get my thought, because that was really good thinking. And, oh, right. So one of the things that I think in our society, so we are very cool as a country. We are go-get-it people. We solve problems. We handle things. We take care of stuff. We don't just sit around and hang out, right? That's not what we do. So in Eastern philosophy, it's much more of a sort of a hangout, like let the pain happen and you just watch it. And here, we need to do something. If you're not doing something, you're not actually being active. So one of the things that's true about treatment, at least in psychiatry, is there's dialectic behavior therapy, which is sadly named because it's so confusing, but talks about distress tolerance and just letting yourself feel the distress. And I think that we are not good at that in this society. If you've got anxiety, you must have Xanax. If you have pain, you must have OxyContin. If you've got a cold, even if it's virus, you must have an antibiotic, because what if the cold lasted an extra day because you were wrong and it was actually, a microbe. So I think that one thing that we can do as a team, everybody, is to think about how can we look at other ways of managing distress rather than just having to fix it right now. I think that one of the things they talk about in Eastern philosophy is that it's not, okay, I'm going to get this wrong, but it's not the pain that's a problem that causes suffering, it's the trying to avoid it that causes suffering. So I think we spend a lot of time trying to avoid feeling uncomfortable, and so that would be one thing that we can maybe all help each other do a little bit of, and exercise. It's the other thing that really you should do.
You really like exercise, don't you?
Dude, brain-derived neurotrophic factor, it's miracle growth for your neurons. Like, your neurons will grow if you exercise.
We have kind of a process thing, because we were going to try and close about 8 o'clock, and it is getting close to that. But I'm wondering if there are a bunch of questions that are just burning, like 8 of them. There's a lot of fire out there, yeah, I think there is. So let's, is it okay if we stay till 8:30?
Yeah.
Yeah?
Yeah.
Anybody who wants to leave, we have not locked the doors. And we're not going to judge.
You're gonna
It's a
have to
very
pay us overtime.
unjudgmental panel.
You're going to have to pay the commissioners overtime, however.
Yeah. Okay, so
regular staff.
Diana has got somebody back there, and then there's a gentleman right here, and then somebody in the middle, and then you. Okay, so we got at least 4 on the queue.
Okay, I'm sure I'm probably like everybody else. I've got so many things going through my mind. I'm not sure which one's going to come out of my mouth right now, but I'm here both as a provider and a patient. I was a nurse practitioner, advanced nurse practice. I was in the Air Force, the Navy, and then I got cut short by a car accident, and I've had 3 back surgeries that were badly failed. And I've been on OxyContin since 2006. And my primary care provider gave it to me until 2013, and then I had to go to a pain management specialist. So there's been a whole blossoming of this whole specialty area. And for her, my primary care doctor, she let me manage myself. Sometimes I'd get it'd be 3-4 months before I saw her again. But now I've got to go every month. And then the doctor that I'd been seeing for 2 years, it was about a year ago, he just kicked me out of his practice. And for no good reason except that I was on the amount that was too much, so I'm wondering, do you guys realize, does the legislature realize that the doctors are scared to death to prescribe anything over this little tiny amount, and they're not properly assessing why are you hurting? Where's it coming from? And who needs it and who doesn't? And like this lady over here with her husband, too, I think that the other side of the coin has been ignored, and the chronic pain patients that really need it. And how are you going to figure that out? Who really needs it?
I think you bring up a really important and valid point, both of you. And so I think our legislator has gone, but that is certainly something we can talk to him about. There was a bill that I don't think passed about limiting the amount. But there is a stigma now about this, and I'm wondering if there is training for doctors about pain management and
they have training, but I had to go to 9 different doctors in the Denver area that were very, I can't even drive, so I either have to ride the Access-A-Ride or bother somebody to take me, and it's an all-day project, and when I get home, I'm in so much pain that then I need more pain medication. So it's just kind of,
Dr. Winter?
if the doctors, the whole point is, I guess, how can you not interfere with the doctor-patient relationship? Because they see us, they see our pain, but they are so afraid they're going to lose their license. I was told it over and over again, I can't give you more than this much, or I will lose my license.
Let's have Dr. Winter address that for you.
So everybody's pain is different, and the problem is that pain's super complicated. Like, there's pain receptors, that's not even the whole part of it, right? There's pain receptors, and then there's systems that inhibit the pain receptors, and then there's systems that manage the meaning of whatever's happening. So pain is very complicated, and it's not like some things, like diabetes, you can take a prick and you know what the blood sugar is, and you can tell if somebody's in pain. We don't have that. So it is very difficult to know the difference. And I do think that at one point we sort of swung to, we're not taking care of people's pain enough and we need to do more. And then now, our job is to first do no harm. And the problem is that sometimes we do harm when we're giving people pain meds, and sometimes we do harm when we're not. And I think it's not a very clear answer. And so most of us get into this because we don't like to see people suffer. And so when people are suffering, we tend to want to give them medications to help with that. The same way that we don't do distress tolerance as individuals, we have a hard time doing it as providers. So it is not an easy answer, and I think the fact is that everybody's pain is different, and I do think that it feels really rotten when you feel like people are invalidating your pain, because pain is really a big deal. It's like snakes. You can't, even if you know they're garter snakes, you can't ignore them, right?
The difference between having any quality of life at all and nothing, it's that different.
I know, yeah. Right. Right, and then there's people that are dying, and so I don't know what the answer is, but it's a very, very difficult problem from all sides.
Thank you. This gentleman here? and then we'll do two more, and then we'll wind it up.
My name is Jacob Meyer. I'm a representative from Behavior Health Group. We're one of the leading opiate replacement therapy outpatient treatment centers in the Denver metro area. And I just would like to make a quick comment to save time. So I think this is a great conversation to be a part of today. And we've been talking a lot about the problem, and what we offer is some of the solution. And so I feel like we've really taken a lot of steps in opening new clinics in a responsible manner. We're growing in capacity as the need grows, and we've just opened up a clinic down in Centennial to be able to service the people of Arapahoe County and to hopefully help. So we're basically focused in the harm reduction method and to keep the client's safety medically first. And those are the two aspects where I think we lead the field, and just in the urgency of time right now, if you have any questions, I have pamphlets that I'm going to hang around after the meeting. So if you'd like to talk to me, if you have a family member that needs treatment, or how to get somebody into treatment, or what we provide further, I'll be at the back here.
Thank you. Okay, we had somebody in the back, and then this lady in the stripy, flamey dress. Yeah, somebody back here.
So I seem to be one of the younger ones here. And this is my first time attending such a meeting. And I am a chronic pain patient since 2000, it's been 8 years now since I had my surgery that the surgeon had messed up on. And now that I have just had constant pain ever since then. And I've lived in about 6 states now, and the doctors are different depending on what state you go to. It's really weird that way. But here in Colorado, people are a lot more liberal and new age about their new medications and stuff, and they're petrified of prescribing opiates, like she said here. And it took me so long to find a doctor to just continue the same dosage that I've been on for 9 years. And here I am making great money. I live alone in a house. I take care of dogs. I have 4 fish tanks. I'm a responsible adult. And people, well, doctors, just look at me as a possible overdose person, you know? And it's terrible.
I appreciate that because, you know, you're I bet you're not alone. Well, I know you're not alone. We've already had a couple of people speak to this issue, that we need to be careful. The cliche is not to throw the baby out with the bathwater, that there are people who have serious pain issues that do need this medication. We just want to prevent the folks that Kelly, Dr. Lear sees, from overdosing. So I appreciate that.
See, that's another thing. I feel like it's not such an opioid epidemic as much as it is a personality disorder epidemic.
Well, you know, the causes, okay, we don't have time to get into the complications because we're going to have to close up in a minute. I'll have Dr. Winter speak to that question of whether it's, and what those interfaces are, and what they found in that. So.
Well, I'm just going to harp on 80 billion neurons again. So everybody's really different, and pain for everybody is really different. The experience of pain is very different. And so I mean, I can completely understand that you're very, very frustrated. I don't think we can blame even the people that die, though. Like, I want to be careful not to have, like, groups of people blaming other groups of people. It is very complicated, and everyone's different. And
Not so complicated, though. Who have passed away? We're just bad people who never went to school or did anything with their life.
So,
And I think what we want to do is try to decrease the stigma.
What else did he have?
I think what we really need to do is decrease the stigma. And I think as we've discussed, we don't want one group of people blaming another group of people. What we're really looking at is ways that we can prevent these things from happening. Not so much that we want to take away somebody's opioids or change somebody's treatment, but what we're looking at as a community is what can we do better. And part of that is, yes, some people do need their opioids, but can we get those stored safely so that the neighborhood kids aren't stealing them? Can we get those people who are overprescribed at surgery to dispose of those responsibly? We're not blaming anybody. We're trying to look at little bits of this and put that together in the best way possible and to find a solution that will help as many people as possible.
That's just a matter of buying a $20 safe.
But that's part of what we're trying to educate the public about. Thank you for your comments.
And we're going to, our panelists may be here afterwards for you to engage in conversation with them, but I'm really mindful that our time is escaping, and I promised this lady here that I would, she's been very patient, so.
Thank you. My name is Terry Schreiber, and I'm a community volunteer. I do some work with the Colorado Consortium, and at the Challenge School, I do a program, a parent coordinator on drug prevention. And my question has to do with, a lot of your discussion was about what do you say to the children, or what starts at home. But to me, as a mother, as a parent, I do that. But then you get beyond that and you actually go into the doctor's office and you run into a problem with the insurance companies. So I'm hearing a number of people here tonight who have problems relative to alternative to opioid treatments, but the insurance companies aren't paying for them. And so if you look at the cost, you could get a bottle of whatever medication for $5, $10, or you could get physical therapy or massage or acupuncture or do mindfulness and meditation, but those things aren't covered. So my question to you is, what do we do, or how do you help us, or the legislator, how does he help us, so we can actually begin to change the conversation about making those alternatives available? So some of the people in the room who are saying, I take the meds, or my husband takes the meds, I am a chronic pain sufferer and I take Tylenol, or I take naproxen, and I go to my massage. And my life, the quality of life is completely different. So if you could help me figure out how we can solve that with the insurance companies, I'd be grateful.
Okay, I'm going to say the serenity law right now because there are certain things that I can't change. So, on the other hand, I do think that, small groups, there's some great saying about small groups of people can change the world. So I think that's true. I bet that there's going to be a lot of motivated people who are in pain that want some change, and people who are watching other people suffer that want some change. So my guess is that this is the moment where the power of people talking about alternative treatments is probably, more likely to change things than they used to be. But people have to work together to do it. Like today? Okay, they're smarter than people than me that can answer that.
That statement was from Margaret Mead, the famed anthropologist. And it is true. I've been in politics for over 50 years now. I may not look that old, but I am. And I've worked both in the Senate and in the U.S. House of Representatives and the U.S. Senate for well over 22 years. And you can, as individuals, make a difference. If you recall the pressure that was put on Congressman Kaufman during the ACA debate, and he turned out voting against it. And he did it because individual people came into this building and others around the county and expressed their concern. And that's how you make change. Change doesn't happen just because it's a good idea. change is made because you are committed and you express yourself to your neighbors, to your family members, to the press, to the to your local and national elected representatives. It can happen. And I think I just gave you a classic example of it happening here in Arapahoe County. But it is a matter of consolidating your interests, finding support, getting the public educated about the problems, and individual commitment. That's the several elements that allow change to happen. You can do it. I've seen it hundreds and hundreds of times.
So Commissioner Holland has just given you the secret. And we're very, very fortunate that here in Arapahoe County, our legislators are very available, especially at the state level, and I know all of the commissioners are as well. So it is, as Commissioner Holland said, it is really important that we work together and we create a common vision and we present that to our elected officials who can change those laws. So I want to give each of our panelists like a minute to sum up whatever last words they have, then I will summarize the panel and then we'll see what happens from there. So Bill, do you want to start the summaries?
I just want to thank everybody for coming out. This is an incredible turnout and I'm very flattered and humbled by the fact that you're here. I'm moved by your personal stories, and I'm moved by your quite apparent commitment to these issues. Together we can make changes. It's not an easy road. I can tell you that when I was working in the United States Senate, it took me 10 years to get a job done, a bill passed through the Senate. Here as county commissioner, we can do it in weeks. So it's a big change, but we're influenced by what you feel and what you need and what your desires are, and you have to express those. Thank you for being here.
Thank you.
I want to close with another success story, a save, if you will. The reporting party stated that there was a vehicle driving sporadically on Arapahoe Road and came to a stop on the right-hand side of the road with a female driver who was barely conscious and a male passenger who was barely conscious. Based on the presentation of these individuals, the deputy determined that Narcan administration was appropriate based on their training. Both victims were transported to a local hospital. At the hospital, one of the emergency department physicians made comment to the Arapahoe County deputy that it was likely the use of Narcan in the field that saved these two overdose victims. So we are doing what we can, both out on the field, providing all of our deputies, our first responders, with Narcan kits in the event that they're needed. If an individual is arrested, we have many, many resources that they can be part of. If it's RISE program, it's the ADMIT program, it's JBBS. Because again, we believe that we need to provide all individuals, regardless if they're incarcerated or not, the opportunity to receive treatment.
Just that you guys are nice and smart, and it's really cool to get to know you guys a little bit.
Yeah, a group hug. I like Bill. I'm extraordinarily impressed that this number of people is interested enough to come out and be part of the film. Number two, we will not help those with chronic pain and reduce the deaths happening in Arapahoe without large community-wide effort. This is a very big part of that. The third thing is that anything we do will require balance and thoughtful wisdom to try to achieve that balance. There's not a magic bullet with proceeding with these things, but I do think this is the kind of dialogue that helps us get to a place to find that balance.
And I'm not sure which microphone I should use. So again, as I'd like to echo, thank you to everybody who's here and everybody who's concerned, and to keep that concern going, and hopefully it will motivate some change. We're really, all of us here, as part of a multi-pronged approach to do what we can. Again, from my point of view, the people that I see, my patients, come from all walks of life, and I see the whole range of people, from people who do have substance use disorders to people who are accidentally taking too many of these pills acutely. It's both a chronic and an acute problem. And part of, I think, what we've been talking about is really reducing that stigma, and something that we work for in my office as well. And I have to talk to families who have lost loved ones and explain to them what happened, how it happened, if I can give them an answer as to how it happened. And that's a conversation I don't want to have. I mean, the fewer times I have to have this conversation, the better, because I don't want more business. I want less business. And whatever we can do to do that is, I think, why we're all here.
Thank you. I have some other remarks, and I'm sitting here thinking, should I even open up another can of worms? But I just wanted to let you know, it was mentioned earlier about the courts and the justice system, and I want you to know that the courts, the DA, the public defender, the judge, the sheriff's office, all the folks that are involved in our justice system are working really hard together on this issue. We have a behavioral health task force that meets monthly, that discusses these issues. We have problem-solving courts that really help guide people with that therapeutic approach rather than a punitive approach. So there is a lot going on in Arapahoe County. It's not enough. We know that. But look at the stellar folks, and these are just some of the folks that are working on these problems, and I think you should be proud as citizens of Arapahoe County that you have folks like this really trying to help solve these really horrific and complicated. How many cells do we have in our brain?
80 billion.
80 billion. And then we have to get along with each other, and that's 80 times 80, so it's very complicated. But I'm proud to be amongst my colleagues here and amongst you. You know, we're all in it together, and I think that it's going to take all of us to solve this problem. It's a big one. It's a national problem. It's huge. If it was easy to solve, we would have done it, right? But it's going to take all of us working together. And so I do also want to add my thank you to the panelists and to those of you who came tonight, to our folks in communications, to Diana and Deidre who helped set this up and make sure we were organized. And last but not least, I want you to take one of these cards with you. So I happen to sit on the Colorado Rocky Mountain Crisis Partners board, and this 24-hour, 7 days a week hotline can not only save a life, but if you are wondering about a loved one and don't know what to say or how to deal with it, you can call them and they will talk to you and give you advice. So take a card with you. It's no charge. It's anywhere in the state of Colorado, wherever you are. Take a couple of them and give them out. So anyway, we want to thank you for your presence here tonight. If we can keep our panelists here for a few more minutes, they'll be around to talk to you. And again, thank you so much for being here and for caring so much about this important issue. Thank you.